Hello, everyone. Thank you so much for tuning in today. Welcome. So today's webinar presentation is going to be just a little bit different. Me, Dr. Lahnor Powell, who is usually your moderator for LiveGDX, I'll actually be the presenter for today. And we're going to be talking about a topic that is actually very near and very dear to my heart, a topic that most mothers, including myself, actually can relate to. The title for the presentation is A Functional Approach to Postnatal Depletion Syndrome. Unfortunately, this idea of postnatal depletion syndrome is not commonly researched, nor is it really discussed in the medical communities, despite how frequent or actually often it presents itself. So this is a newly coined term in the medical profession in 2018 by Dr. Oscar Serrallach. And so as functionally minded clinicians, what's really awesome is that we have a lot of testing and treatment options that we can actually employ to help support the mother during this time, which is really super duper exciting. So here's my picture. A little bit about me. I received my doctorate of naturopathic medicine from Southwest College of Naturopathic Medicine, followed by a master's of public health from the University of Alabama at Birmingham. After the birth of my beautiful children, I realized that there was a significant gap in our medical system in really caring for the mother. Only at your 6-week visit or follow-up appointment after the birth of your kid, all they simply assess for is postpartum depression, which is super important, but that was it. I had these series of non-specific symptoms. I almost felt guilty complaining about it because I thought they were normal. After all, I was a new mom, right? But after many months, the symptoms I experienced, they persisted and they actually started to impact my quality of life. And so I realized that many, if not most women, actually have experienced or were experiencing these same symptoms. And so it really led me into a deep dive into literature and buying a whole bunch of Amazon books to really try and sort out exactly what is happening to the female body, especially after she gives birth. So let's go ahead. Let's begin. Let's kind of just dive on in here. Hopefully you're as excited as I am to review this topic. Before we get started, I want to give you some key phrases that you may actually hear from your clients that can indicate they are dealing with postnatal depletion syndrome. So you might hear this phrase: my symptoms started after the birth of my child, or before the birth of my child, I was completely healthy. Or when you review the timeline of when the symptoms started, you notice that it happened after the birth of a child. These are really key phrases or observations that we should start paying attention to as clinicians, because you may actually be dealing with a patient who has postnatal depletion syndrome. So here's what we have on the agenda today. Again, please feel free to send questions to the moderator. I'll try to address them at the end of the presentation. So these symptoms, postnatal depletion syndrome, they arise from physiological issues, hormonal changes, but also the interruption of this circadian day-night rhythm of a woman's sleep cycle, layered with psychosocial, mental, also emotional components. There's 3 primary factors at play here. Number 1, nutrient insufficiency. So the nutrients given over to making, incubating, birthing the baby. Imagine if the mother is breastfeeding for any extent of time, these nutrient depletion symptoms may actually persist a little bit longer. Exhaustion from just sleep deprivation or lacking a good night's sleep. And the mother's new role, often accompanied by social isolation. Nowadays, the family units are moving away from the grandmothers, the grandfathers. It's moving away from, that immediate support of family. And so there is this social isolation, especially with the pandemic and all of the different regulations that have gone forth. Poof. Before you know it, you have a sleep-deprived, cranky, short-tempered, hair-thinning, quickly aging mother who's basically starting to regret and possibly resent her family, and in the midst of it all, has maybe even lost who she is in this whole process. So one of the things I find very interesting is when you start to look at other cultures, you notice that postnatal depletion syndrome is actually more common of a phenomenon in Western societies. And so the question is really why? I think it has a lot to do with our lack of postpartum care, both the emotional and physical support, coupled with high performance expectations. So, your job, your household duties. And when you look at Western societies, postpartum care, you realize that there's no guarantee for paid maternity leave. And most women return to work or school after like 2 to 6 weeks of delivering their baby. So there really is little time for true recovery. Whereas other cultures implement bed rest, specific nutrient dense foods are delivered or cooked for that mother, as well as other healing rituals or practices, really to replenish that mama, which we lack here in our Western societies. So let's look at this list of common postnatal depletion symptoms a woman might experience. Many are very non-specific, like baby brain or fatigue or low libido. Remember, a mother might experience one or maybe possibly a multitude of these symptoms. For me personally, it was really anxiety about something was going to happen negatively to my family. I remember having my husband pull aside while we were driving because I was sure that my daughter sitting in the back seat who coughed one time was choking and she could not get air and we were going to need to perform the Heimlich maneuver. So you have this sometimes anxiety that's really unproportional to what the situation is. Joint aches and pains, I had it in my fingers and in my hands. I would get a lot of stiffness. So as a clinician, I'm automatically thinking, oh no, inflammation, autoimmune disease. Also hair loss by the fistful to the point where it would actually, I would cry every time I had to wash my hair because I was just losing so much hair and the perimeter of my hairline was thinning. I mean, it was crazy. I was extremely irritable, very snappy. Plus, I had skin texture changes. I think some people might call it cellulite, but I'll just be nice and say skin texture changes. And so what contributes to the duration of postnatal depletion, it can be the baby's health status. So if you have a baby that was born prematurely or had to go into the NICU, that might actually prolong the postnatal depletion syndrome. Breastfeeding, depending on how long the mother breastfeeds the child. The mother's diet, the mother's nutrition status. What about pregnancy-related complications as well? That can also contribute to this postnatal depletion syndrome. Give me 1 second. I'm hearing some echo feedback. Let me see what might be causing that. I'm not quite sure. Hopefully it's okay. Hope you guys aren't hearing too much of that. Other things that can contribute to postnatal depletion syndrome can be the pregnancy-related complications like hypertension during pregnancy or increased blood loss during pregnancy. What about the social support system of that mama? If she doesn't have a good social support system, then again, this postnatal depletion syndrome can actually last pretty long. What about sleep? Are they co-sleeping and the baby's kicking them all throughout the night or waking the mom up every few hours for feeding or night terrors or whatever it might be, depending on the age of the child, but also stress management. The same stress management techniques you use prior to birth, more than likely is not going to work as well after you give birth. You might need to kind of step it up just a little bit. And this is why you actually can experience postnatal depletion up to 10 years after the birth of your child. And let's just be extremely honest and real. Most mothers within that 10-year time frame might actually have become pregnant again or had another 1 to 2 kiddos added on to their family unit, which would just prolong this postnatal depletion syndrome. So for today's conversation, we're going to focus mainly on 2 topics. Although there's a ton of topics we could talk about, we're really going to focus on nutrition as well as adrenal health. And these are the nutrients that we are going to run over or talk about today. So first, we have to talk about iron. A little bit of information about pregnancy is that your blood supply actually can increase up to 50%. Therefore, when we have this increasing in demand for iron as well, just to make more of those red blood cells during pregnancy. And so after you deliver your baby, that's when you will see a decreased demand for your iron. However, a person can actually still be deficient if they had heavy bleeding during or after having multiple births. And so the average person, vaginal delivery, single baby, the mother will lose up to 2 cups of blood. If there's a C-section or multiple babies being delivered, the amount of blood that can be lost can be higher than that. We typically call this postpartum iron deficiency anemia, and it can last anywhere from 6 to 12 months after giving birth to your baby. Common symptoms of postpartum iron deficiency anemia are listed here. So we can have things like low energy, mommy brain, or being forgetful, which can impact normal everyday activities. You can be extremely irritable or have other mood issues like postpartum depression. You can see here that iron is actually an important cofactor for your catecholamines. It helps convert phenylalanine into tyrosine, and tyrosine into things like your dopamine, norepinephrine, as well as your epinephrine. As well as iron is a cofactor that helps us to create serotonin because it moves tryptophan into 5-HTP, which will then eventually make serotonin. A mother might also experience we also might experience pronounced fatigue that can last more than a couple of weeks. That's another potential symptom of iron deficiency, as well as frequent headaches. And so iron dosing really depends on the severity of the iron deficiency anemia. We really rely on serum hemoglobin and ferritin to determine the severity of the anemia, and that's how we understand the iron dosing there. In general, I usually use at minimum, the RDA recommendations for pregnancy, which is about 27 milligrams daily for women who are experiencing postpartum iron deficiency anemia. I use the glycinate form to avoid constipation and darker stool color. But again, that dosing is really dependent or predicated upon the values we get back from serum hemoglobin and ferritin. I also remind mamas to take their iron supplement away from other nutrients so that there is not that competition, as well as take their iron with vitamin C because it will actually help to enhance absorption. Another nutrient whose need increases in pregnancy and typically decreases after pregnancy is copper. So the reason that copper increases in pregnancy is because it helps us to make red blood cells and vessel formation, which is extremely important for that placenta. But after pregnancy, the copper should actually decrease. And if it doesn't, we can experience what's called copper excess. So this is one of the only nutrients in which we'll talk about an excess issue. Because copper is known to convert dopamine into norepinephrine, we have this tendency to move more, have this tendency to have lower dopamine, and dopamine is like your pleasure, your well-being neurotransmitters. So you become less engaged with lower dopamine. You become less excited about interests. Sometimes it's linked to depression. And because we have higher norepinephrine, because of higher copper levels and pushing that conversion, we will be more vigilant or have greater anxiety, basically the effects of the neurotransmitter norepinephrine. And some experts think that copper might also contribute to postpartum depression excess, just like iron deficiency can also potentially contribute to postpartum depression as well. Copper causes oxidative damage that can also lead to inflammation, and it can block carnitine, which is really important when you think about how we metabolize our fats for using them within the citric acid cycle and for energy or ATP production. So it actually can lead to fatigue. And so when you're assessing copper, you should also look at serum zinc because they're actually what's called antagonist nutrients. So if you see that there's high copper upon testing, you could actually use this copper zinc relationship, provide the patient with a zinc supplement, about 20-30 milligrams daily, and encouraging them also to decrease copper intake, because again, remember, their copper is in excess. So you want to decrease the dietary intake. You want to make sure they're not using copper cookware, and you want to have their get their water tested or make sure their water filtration system is certified to clear copper. I usually like to send people to the ewg.org website. It's a great guide when helping to decide which filtration system to consider for water. Zinc is the next nutrient, which honestly, I really don't think it receives enough recognition as an important nutrient, because it's actually a cofactor in more than 300 different enzyme systems. And so although the list of zinc function is extremely long, let's just focus on the ones for postnatally depleted mothers. So we know that zinc helps to promote digestion. So it's going to assist in making stomach acid. It keeps your immune system strong. It makes DNA. It helps with your brain neurotransmitters, and you can see here that zinc is a cofactor for converting 5-HTP into serotonin, which, that's why we have this idea that zinc has an antidepressant effect. Plus, it also regulates hormones like testosterone and prolactin as well. Think about milk production. So if deficient, according to testing, for zinc, I usually use the picolinate form, and I consider anywhere between 20 to 25 milligrams. Magnesium, your mama mineral. In the book by Dr. Oscar Serrallach that he has called Postnatal Depletion Cure, he actually calls magnesium the momnesium, which I thought is super cute. But it's important for sleep, GI function, energy production, mood balance, right? So just as zinc is the cofactor for moving 5-HTP into serotonin, magnesium is also an important cofactor there as well. It supports bone health as well as your adrenals. And so just like zinc, magnesium activates about 300 different enzymes in the body. And so when we have low magnesium, we can experience any 1, 2, or more of the listed symptoms that you see on your screen. Now, when it comes to magnesium, I consider either the malate or the glycinate form, dosing usually from 400 to 800 milligrams daily. When we think about constipation, I'll use the citrate form. And then if they have trouble with, sleep or want some kind of muscle relaxation impact, we can also consider bath salts that can also help with constipation as well. The next nutrients we're looking at here are the B vitamins, needed for energy production, methylation, for a healthy mood, which you can see on the right-hand side, that diagram there. You can see it's, the neurotransmitters. You can see that it's needed for amino acids, as well as the folate cycle. And so usually a quality B complex will contain appropriate amounts for repletion. You can also consider IV therapy to help boost the B vitamins really quickly. The part I always remind clients is that birth control, which is very prevalent with this mama population, can deplete B vitamins. Stress can deplete B vitamins because your adrenals have a high demand for stress, or for the B vitamins. Alcohol plus caffeine, these are all factors that can actually lead to a depletion of the B vitamins. So it's not just important to replace the need, but we have to also figure out, why do you have such a high need in the first place? Then we have our fat-soluble vitamins, vitamin A, D, E, K. They're important for your immune system, for bone health. They're wonderful as antioxidants. And the key is that you have to have appropriate fat intake, number one, but also you have to have good digestion and absorption of your fats to actually absorb these nutrients. Vitamin A, typical dosing is usually 5,000 to 10,000 IU, but please remember that vitamin A at doses above 10,000 IU can actually be toxic to a fetus. So if the patient becomes pregnant, they need to inform you immediately so you can, look at how much vitamin A they're taking and make those adjustments. Vitamin D, the dosing really depends on how severe your deficiency is. We can consider a loading dose of like 5,000 IU or higher for a short period of time to increase the vitamin D quickly, but then we usually will back down to a maintenance dose of about 1,000 to 3,000 IU daily. Again, it really depends on how severe the deficiency of vitamin D is. For vitamin E, about 400 IUs is mixed tocopherols, and for vitamin K, unless osteoporosis, I usually just stick with dietary sources like free-range eggs or fermented foods, but we aim for about 60 or so micrograms daily. Vitamin C, very important for immune health, collagen synthesis as well. One thing I always like to remind patients is that collagen is very important for the recovery after you deliver your baby. But also collagen is a really cool antioxidant. It supports healthy mood. And if you look at the diagram to the right-hand side, all the yellow dots represent vitamin C. And so you can see astrocytes, the presynaptic, the postsynaptic neurons, and basically the vitamin C plays an important role here in giving us this antidepressant, anti-anxiolytic-like effect. But also vitamin C is really important for your adrenals. Typical dosing ranges between 1,000 to 2,000 milligrams daily, and some patients may have to use lower doses, really depending on their bowel tolerance. But vitamin C is actually a great transition into us talking about the adrenals and how that links to postnatal depletion, because again, vitamin C is an extremely important nutrient for adrenal health. But before we go into the adrenals and cortisol, I think we need to really make sure everybody understands what happens to all of your hormones during pregnancy, so we have this appreciation for the roller coaster that women typically will experience here. So estrogen, represented in the pink, it increases up to 30 times your pregnancy levels, but then it drops by 90 to 95% after delivery. Progesterone, represented by the purple, will increase up to 200 times your normal levels and then drop to menopausal levels after delivery. And then we have CRH, or corticotropin releasing hormone. So that stimulates ACTH, or your adrenocorticotropic hormones, which stimulates cortisol and glucocorticoids and mineralocorticoids and DHEA. And you can see the CRH, again represented in orange, increases and keeps going up until delivery, and then it will drop back down, but it does increase throughout the trimesters. HPL is represented in that reddish color. That's human placental lactogen. It helps to support the baby's nutrition regardless if the mother is malnourished or not. So it actually will decrease insulin sensitivity, it'll decrease the mother's use of glucose, and it'll increase fat breakdown so that the baby has the right fuel and glucose levels for growth. And so you see with the HPL that as the trimesters progress, it does, it has a little increase there, and it does dip after the delivery of the baby. Oxytocin, the love hormone, involved in childbirth and breastfeeding, which is why it peaks later on in the pregnancy. And then we have lastly your thyroid hormone. It's not represented here, but your thyroid hormone can actually increase 50% by the third trimester. And it can shift to over or underactive during pregnancy or even after delivery. In fact, 1 in 12 people are diagnosed with Hashimoto's postnatally. So when it comes to cortisol, initially in pregnancy, the mother produces the cortisol not only for her, but the baby. But in the last trimester, your placenta will actually take over. Cortisol, produced by adrenal glands, the adrenal glands that sit on top of your kidneys. It's important not only for energy balance, but it's also released or triggered by stress. And so when the placenta takes over the cortisol production in the last trimester, it's thought to possibly explain why women get those strong urges to clean their house and clean and detail their cars and spring cleaning and cook a bunch of frozen meals, basically prepping for the new baby, or sometimes we call this nesting. So normally we have this stress on, stress off pattern, and the stress on or increase in cortisol helps us to, for example, wake up in the morning. And at night, the stress off or decline in cortisol will help us to go to sleep. So cortisol production, this on-off system or pattern, is actually not bad. It's very helpful. But as a mother, we tend to experience multiplying demands at the same time, not allowing us to actually have this stress off or relaxation period. And this is what's thought to contribute to baby brain or forgetfulness. After a period of stress on, right, the body will lose its ability to actually mount this cortisol response to a situation, and its production will begin to decline. And we often term this cortisol dysfunction or cortisol exhaustion. And the treatment usually consists of lifestyle changes, vitamin C, your B vitamins, and sometimes even herbal adaptogens. Although if the mother is still breastfeeding, we have to be careful which herbal products we consider utilizing. So let's go ahead and apply the information that we just discussed to a patient. It's going to be a 34-year-old stay-at-home mother who experiences postnatal depletion. Unfortunately, she's been told that her symptoms are normal for a mother. It comes with the territory. It's all psychological, or it's in your head. These are all phrases that prevents mothers or makes them hesitant from seeking help in the first place, which is very, very sad. So again, we have this 34-year-old mother, stay at home. She has 3 young children, and her chief concerns are anxiety, a new onset of panic attacks. She has joint pains and aches. She's exhausted. Her sleep is horrible. She has headaches. She craves sugar. She has GI issues and low blood pressure plus poor libido. So because she's a stay-at-home mother, she does have the ability to cook all meals, but she does go through several cups of coffee daily. And remember, we did mention earlier that coffee is a factor that can actually deplete your B vitamins. In terms of medications or supplements, she's on hormonal birth control. Again, another factor that can lead to a depletion of some of those nutrients, including B vitamins. She exercises 3 times per week, light cardio, only 20 minutes, and then has a very strict morning meditation regimen. Socially, she has little local support, plus her husband travels a lot for work. So she's really the predominant one taking over this household and making sure everything's being managed, but her social support system, it lacks severely. And so here we have our nutrient need overview. And so on this nutrient need overview, what we see is that this patient has a need for several antioxidants. She also has a need for several various B vitamins, as well as minerals like magnesium and zinc, which are minerals we talked about for postnatal depletion. And then we have this need for GI support. Remember, the GI support might actually be a reason, GI dysfunction might be a reason why she is deficient in these nutrients in the first place, despite her best attempts at a good, healthy diet. And if you look at the bottom of the page, we have amino acid recommendations. She has quite a few of them, and these are just how many she needs to get above the bottom 25th percentile of normal. And so when we start to look at what we're seeing here, we see a need for tyrosine on the bottom right-hand side. Well, remember, tyrosine is one of those amino acids that can actually help us to make norepinephrine, epinephrine, dopamine, as well as support thyroid function. She also, we see here, she has a need for methionine on the upper right-hand side. Methionine is very important for methylation. She has a need also for some of the branched chain amino acids like isoleucine, leucine. So she might not be experiencing increase in muscle fatigue when she wakes out, or she might not recover adequately in between workouts. We also have this cysteine, glutamine, glycine deficiency here on the left side, which are all amino acids needed to help build glutathione. So they're pretty awesome antioxidants. Remember, she had headaches. And she also has on the upper left side a need for arginine. And so when it comes to arginine, this is the precursor to nitric oxide and actually can be used as a therapy for individuals who have headaches. but we have to be careful because we also did see that she tends to have a lower blood pressure. And because arginine is a precursor to nitric oxide, we just want to be cautious with giving too much because it can also lower her blood pressure too much. So these next few pages of the report, I absolutely love them because they're the interpretation at a glance. They really provide a functional imbalance score out of 10 for each nutrient. And the higher the number, the greater the need for support for that nutrient. But under each of the individual markers, we tell you what's the function of the nutrient. Why would I be deficient in the first place? If I'm deficient clinically, what might I experience? And the last little bullet point that's red talks about different foods to eat that can help increase your exposure to these nutrients. And so here, great learning resource for your patients. We have the antioxidants on this first page. The B vitamins are listed here on the second page. On the third page, we have our recommendations for the minerals, as well as the omega-3s. Now, her functional imbalance score of the omega-3s, it's a 4 out of 10. So it's not quite elevated, but we are going to assess this a little bit further to see if she could actually benefit, because she did mention some aches and joint pains, and we know that omega-3 has a really awesome anti-inflammatory impact, but also, you know, if, the omega-3s can help support brain health as well, especially the DHA if the mother is experiencing forgetfulness or something like that. Lastly, under the interpretation at a glance pages, we have our microbiome support, digestive support, and that's based on some organic acids that I'll point out specifically. For the need for microbiome or digestive support, sometimes we might consider following up with a stool test to kind of evaluate things in more detail, but we'll get there. And at the bottom, we just repeat a few of those functional imbalance scores that's reported on the first page of the report. And again, still providing a functional imbalance number. And so you can see for mitochondrial dysfunction, that one's really going to be based on amino acids, as well as your B vitamins, your minerals, the need for carnitine, and even CoQ10. Now, your toxic exposure, that's just looking at oxidative stress markers and exposures. And your methylation, that's based on your B vitamins, especially the latter ones like the 6, 9, 12, and your amino acids. So if we're deficient in any of those categories, it can definitely contribute to this functional imbalance score that we're seeing for either one of those categories. The next page of the report, we start off with the organic acids, looking at the citric acid cycle. You know, the goal is to take these macronutrients and metabolize them into making ATP. That's the eventual goal. But unfortunately, we can have cellular metabolism backups or blockages. And so when we look around the cycle, we notice that cis-aconitic acid here. Let me get my pointer so I can show you exactly what I am looking at here. So cis-aconitic acid as well as isocitric acid are trending low. And we do know that basically with these trending low, it actually could be that you don't have adequate amino acids to actually help move this to the next step. We have alpha glutaric acid trending high, and it could be deficient nutrients to move it forward. And then succinic acid trending high could also be deficient nutrients like iron or B2. So we want to make sure that we do an iron evaluation for this patient to make sure that's not contributing to some of her symptoms. And then malic acid trending high could also be a B3 deficiency. At the bottom of the page, we have our electron transport chain, where we're really looking at this balance between free radical markers like lipid peroxides, which represents oxidative damage to cell membranes, as well as glutathione, which is an antioxidant, and this is trending low. But remember, what is glutathione? It's basically a bunch of amino acids, right? The glutamine, glycine, cysteine. So it's really hard to have appropriate glutathione levels if you don't have the right amino acids. So next page, we have our malabsorption and dysbiosis section. So here, the malabsorption section, that will drive the recommendations for a digestive support. either an enzyme or something like that, I really like to further question the patient, see if they have dyspepsia, which might be a sign of low stomach acid, to see if potentially they have greasy or foul smelling stools, which can be a sign of fecal fat malabsorption, or if there is a depletion or an issue with just foods in general, which might be a sign of pancreatic enzyme insufficiency. And then for the dysbiosis section, here we're looking mainly at metabolites of bacteria, and here we're looking at metabolites of fungi. And so with some of these being elevated, if the patient has clinical symptoms, we want to make sure that we follow up with a stool test or appropriate measures. This is the citric acid cycle that we just talked about on the previous page on the bottom left side of the report. And on the upper right-hand side, we have our branched chain catabolites. We're assessing these specific nutrients, B1, 2, 3, and alpha lipoic acid. But for glutaric acid being elevated specifically, we're thinking about the need for B2. And then with our neurotransmitter metabolites, we have our the serotonin marker here, the 5-HIAA, that's on the higher side. So here it can indicate dysbiosis in the GI tract, or it can indicate the need for nutrients like magnesium, manganese, or B vitamins as well. And then under toxin detoxification markers, we have this marker here, alpha hydroxy isobutyric acid, which is an indicator for MTBE exposure, a gasoline additive that we don't any longer use in the US. However, this actual gasoline additive, it can be coming from our drinking water. It can be coming from even ice when we go out in public. And so I just like to tell people, check out the ewg.org website to make sure your water filtration system is certified to clear MTBE. The next page of the report, we have our oxalate markers. And so for the oxalate markers here, we do have this glyceric acid that's trending low. Well, we have to understand glyceric acid actually is derived from serine, so an amino acid, right? But also fructose, which comes from like your fruits and your veggies. And so decreased intake of fruits and veggies or decrease in your amino acids can actually lead to glyceric acid trending low. We next see the low glutathione, 897, but again, because it's made from amino acids listed on the left-hand side, we have to really rebuild those amino acids to have a better amount of glutathione. But also your body will deplete glutathione if you have elevated oxidative damage markers. And for this beautiful patient, she did have lipid peroxides, which represents oxidative damage already done to cell membranes. It was elevated. And so you can throw at the patient all day, all night, antioxidants, that's fine, but what's the root cause? I really like to start off with just kind of basic blood panel, CBC, CMP, thyroid, fasting insulin, fasting glucose, just to kind of see what's going on. And if we don't find anything in basic blood workup, we also throw in iron because she is postpartum. But if we don't find anything in basic blood workup, then of course the antioxidants, we still give them, but we just need to be vigilant and try to figure out what it might be. Is it potentially environmental exposures, for example? At the bottom of this page, we do have some pathways or methylation markers that you can look at to better understand why, when this specific vitamin marker is elevated, we have a need for the nutrients. So next we are looking at our amino acids. So I said amino acids a lot already, so we know that there is this depletion here, or we don't have enough intake, or maybe there's a problem with her diet or digestion. But if she's exercising, then she could just be burning through those amino acids super duper quickly. But if you look down the center of this green zone, that's where you want the majority of your amino acids to fall. And you can see very clearly for this patient, she is trending quite low here. And so in this case, definitely considering an amino acid product could really help her, not only with energy, but also her headaches, right? Because we talked about the arginine. It can also help with mood balance because we talked about the phenylalanine and how it converts into tyrosine for catechol choline production as well. The right-hand side of this page where we have the intermediary metabolites, we're looking actually pretty decent here. We're not seeing anything that's really out of range, but look here at the dietary peptide-related markers. Again, we have to look back at signs of maldigestion and or malabsorption for this patient. For your fatty acids, we can look at those omega-3s here. So EPA plus DHA actually gives you your omega-3 index, and it's only a 4.7. So it's not bad, but she has, right? She has joint aches and pains, so inflammation. So I would actually strive for this omega-3 index to be a little bit higher. Now, I do recognize on the previous page, we did talk about lipid peroxides being present, and there is information that taking fish oil can increase oxidative damage to the cell membrane or increase your lipid peroxides. So we have to make sure this patient has some really good antioxidants on board, especially if we consider giving her some omega-3s. Now, I would consider an omega-3 product that has a lower ratio of EPA to DHA. So for example, I would not consider a product that has 1 molecule of DHA to 4 or 5 molecules of EPA. I would consider something that's more of a 1-to-2 ratio or 1-to-1 ratio, because again, the DHA is super duper important for the brain health and just for, you know, that mommy brain forgetfulness kind of thing that we tend to experience. Her omega-9s and her saturated fatty acids look good, especially when you compare it to her monounsaturated fat. She has a really nice trans fat, so she's not snacking on a lot of poor foods here, so that's awesome to see. But we see here under the omega-6 is that her GLA is not converting very well to DGLA. Now, that conversion happens with an enzyme called elongase, and it requires cofactors like B3, B5, B6, B7, as well as vitamin C. And all we're doing is adding on 2 carbon molecules. And the reason DGLA is important is because it stimulates the same anti-inflammatory series 1 prostaglandins that EPA DHA does. You know, unfortunately, omega-6s have received a really bad rap for being pro-inflammatory, but that's not the case with all of them. And then lastly, we have our nutrient elements here. And so looking at the nutrient elements, we can see that we have a low trending magnesium measured in red blood cells. We have low trending potassium here, as well as selenium, right? So think about selenium for like your thyroid, okay? And for toxic elements, remember, this is all current exposure. So she is by definition in reference range, but we just want to let her know this is only what you're exposed to now. What you might have been exposed to a year ago or, you know, 6 months ago, we don't know. And so if she's concerned with environmental exposures of heavy metals, we might have to follow up with other testing measures or urine or provoked or something like that to better understand what her prior exposures or her storage sources might be. So when we think about a treatment plan for this patient, definitely looking at a multivitamin that's going to help cover quite a few of the nutrient deficits that we have here. I also think about a fish oil. Again, we're going to try for something that's like 1-to-2 or 1-to-1 ratio. A protein powder daily, which that's going to give you a lot of your essential amino acids, which with the multivitamin containing the B vitamins will allow us to convert to make the non-essential amino acids, which is really important for glutathione making. For GI support, thinking about things like probiotics, really assessing her for what part of digestion might be off, or should we just give a broad digestive product, and definitely considering a stool test for her. And because of the citric acid cycle and some markers that we saw on there, and the fact that she was dealing with fatigue or exhaustion, we also want to encourage consumption of iron-rich foods, as well as get a serum hemoglobin and a ferritin measured as well. So when we look at this patient's adrenal cortex stress profile, we see that this cortisol awakening response, which is really this anticipation marker, this reaction that happens within the first 30 minutes of waking, we want it to be 50% or greater, and we see that it looks pretty good. So we really want to continue to encourage her to stay with her morning meditation routine. And so looking at the salivary cortisol here on the right-hand side, the morning looks good, the 7 a.m., 9 a.m. looks good, but then it drops off pretty steeply. And so one of the things that we may consider for preventing this steep drop of cortisol is licorice, because it can help prolong the half-life of cortisol. Now, licorice has been shown to cause a pseudoaldosteronism effect, so it can lead to higher blood pressure. So we want to make sure that she monitors her blood pressure. But remember, in the beginning, we said that she actually deals with low blood pressure issues. So again, in the morning, giving some licorice might help prevent that steep drop. Then we see her next reading at 3 p.m., 5 p.m. It does, drop again, and it's still trending a little bit on the lower side. And then the nighttime reading pops up. So we want to figure out around nighttime what's going on. What's your sleep routine with your family? Do you have a lot of blue lights in your environment? Do we need to consider like a magnesium bath at night for relaxation? But you can see on the right-hand side some treatment considerations here. We also want to evaluate the thyroid, because the thyroid is involved in the endocrine system along with your adrenals. And then we see the DHEA here on the bottom left. It's trending low at 80 pg per ml. And so you can consider a little bit of DHEA for a short period of time, even maybe going up to 10 milligrams. However, in my experience, I see that when you fix the cortisol, you usually see an increase of your androgens. But this patient does have symptoms of low libido, so considering DHEA is definitely a consideration here. So with a female patient that reports, my symptoms started after the birth of my child, or you notice that the symptoms started, or you notice when you do a timeline that that's when those symptoms started, there's a few things that we actually want to consider evaluating in a functional approach. Again, for today, we really covered just the nutrition and the adrenal part, but there's a few things more that we need to look at. So look at the emotional liability of the patient. Is there depression and or anxiety? How does it really impact their role as a mother, a wife, or how does it impact their job or their relationship with their children? Make sure you have available screening tools for not only depression, but also for postpartum depression. We also want to make sure we assess the patient's diet as well. What's your sleeping habits? What about the social support system? So let's say for the diet, I call it the toddler scrap diet, where the mother basically just eats the scraps from their toddler's meals. Or is the mother actually getting in 3 balanced meals and healthy snacks with proper hydration? When it comes to sleeping, what are the arrangements? Ask the mother, walk me through your bedtime routine. Who helps put the kids to sleep? What time are the little ones put to sleep? What time do they actually fall asleep, right? Because that sleep time can actually last several hours sometimes. And then what do you do after the kids go to sleep? When it comes to the social support system, do they spend a large amount of time on social media? If they do, they may need to take a mini holiday away from social media just to decrease the negativity. Do they have a friend circle that helps watch the kids or babysits, or family members that can come over and help them out? What break does mommy get? The next one, we talk about exercise regimen. Does the mommy have diastasis recti, or separation of the abdominal muscles? There are several exercises that we know we should not do, like your traditional crunches or sit-ups. And they may need to consider therapy for helping that diastasis recti. Maybe she's embarrassed that she has incontinence or leaks urine during straining. And so she's embarrassed to go to a gym or actually do some physical activity. That should be addressed or assessed further, and considering things like physical therapy to really remove this as a hindrance for exercising. The next one is follow up appropriately on any pregnancy-related complications. So if the mother had gestational diabetes, make sure you measure the fasting glucose, HbA1c, and insulin at minimum, maybe even a C-peptide, and talk about their risk for future diabetes. Look at their diet closely for those foods that can actually trigger glucose spikes, like your high glycemic foods. Did the mother have preeclampsia during pregnancy? Make sure that patient has an at-home blood pressure monitor in which she's tracking her blood pressure. Evaluate the diet and how that might contribute to blood pressure dysregulation. Make sure the patient is physically active, especially cardio activity. Did the mother have heavy bleeding at delivery? You want to make sure you follow up with iron, ferritin, hemoglobin, ask about their current menstrual cycles because they do tend to change after delivery of a baby. How many days, how long do they bleed, how many tampons or pads they use daily, all that information to really assess, do they potentially have heavy blood loss? And then lastly, we should also consider the following functional medicine tests. So number one, nutrition testing, right? What we just looked at. You have to understand the micronutrients because even though in the case that we just discussed, the mother was a stay-at-home mom and she cooked all her meals, we still did see deficiencies in quite a few of those nutrients, which might stem from her exercise, it might stem from her birth control, it might stem from her coffee intake, or even just GI dysfunction. We also might want to consider a GI stool test, which actually for the case we reviewed, that would be the next steps for that mama to basically understand how well are you digesting and absorbing your foods and what areas can I really help you out in, and is there any dysbiosis or something else that we need to look at. And then lastly, hormone testing. Know what the mama's sex hormones are postnatally. Measure the thyroid. Remember, 1 in 12 people can have Hashimoto's postnatally. So get some antibody levels there, especially if there's a family history, and as well as adrenal health testing like we looked at earlier. And so I just wanted to kind of bring up in the last few moments of this talk, and I'm going to go through these last few slides pretty quickly. I just wanted to make sure you guys have them as a reference because I do want to get to a few questions. But let's actually kind of talk about what's the mama's nutritional need during lactation or breastfeeding. So if you look to the right-hand side, I think this is such a cool little picture because it actually tells you how big a newborn's stomach is. So at day 1, it's the size of little cherries, which is so cute. And it increases its size over those 2 weeks after birth. And so you can end up actually feeding your child about 8 ounces per serving after a few months of life. Trust me, this is extremely draining for the mother to produce the milk. And if they work, they have to now pump and store enough milk to sustain that baby during the day while they're at daycare. Okay, many women are now realizing the benefits of breastfeeding, and they're breastfeeding up to 2 and 4 years after delivery of their child. So you can only imagine how this can actually prolong the postnatal depletion syndrome timeframe for that mama. So look at how neat your body is, the woman's body is, when it comes to breastfeeding. The nutritional content of breast milk, it actually changes what the babies need. You actually see this when the mother or the baby are sick. You'll see the milk turn a yellowish color, which is linked to higher immunoglobulins and immune protective cells within that milk. We can also see that basically the mother's diet directly impacts the composition of milk. So if the mother has a lower fat intake in the diet, you will actually see that it impacts the fat amount in the milk, and it can lead to poor satiation by the baby. Also, look at the water content here. Look how prominent that is. So if the mother does not have adequate water intake, it can also lead to decreased milk production. So this is why breastfeeding is a workout by itself, right? It can be extremely exhausting. It requires about 500 additional kilocal per day beyond what we see for non-pregnant women. So it has a high demand for energy. In fact, you have to increase your protein consumption by 25 grams per day when breastfeeding. And many women find that extremely hard to do. So, looking at protein powders to help them out, like a smoothie or something might be something to look at. But if the mother has poor nutrition, guess what? The milk is going to reflect that as well. And just really quickly, these are just some, based on RDA recommendations, these are just some nutrient amounts to make sure the mother is getting while they are breastfeeding. And on the left-hand column, you can see the mother's diet directly impacts those nutrients. But on the right-hand column, despite the diet for proper breast milk nutrition, the body will actually pull this from the mother's sources. So this is why with the calcium, for example, you could actually see bone loss during breastfeeding, but also mothers could actually lose teeth, not only during breastfeeding, but also in pregnancy. It's because they might not be consuming enough calcium for the baby and for themselves. So there you have it. Hopefully you were able to not only define, but recognize the symptom patterns of postnatal depletion. And in my experience, when you validate what the mothers are dealing with, they feel heard and they realize that it's not all in their head. And with the tools presented here today, you also now have the resources to conduct a thorough postnatal depletion evaluation, including knowing which functional medicine tests to consider. And so I want to thank everybody for hanging out with me. And I will now go ahead and take some questions. Let me see. I'm going to look here to see what questions we have. Okay, awesome. So let me just address this first question. I know I talked a lot about micronutrients, but I do have a question here about macronutrients. And so on average, the daily woman needs about 1,800 calories daily. And when pregnant, they need an additional 200 to 300 additional calories, and in breastfeeding, 500 additional calories. And so when it comes to proteins, the average woman has about 45 to 60 grams of protein daily, but in pregnancy, it needs to increase by 10 grams, and when breastfeeding, an additional 20 grams. For fats, about 20 to 35% of your diet, your fat should kind of contain that amount. But when pregnant or breastfeeding, it actually goes up to 25% at minimum to 35%. And when it comes to carbs, the average woman should get about 150 grams of carbs in pregnancy, 175 and breastfeeding to 10 grams. Not junk carbs like your white flour and sugar, but things like your veggies, your legumes, and your fruit. Okay, so another question, I had somebody ask to repeat the nutrient, some of the nutrients we discussed earlier, and just kind of the recommendations here when we have patients that are deficient. So with iron deficiency, I usually use the glycinate form, about 27 milligrams. When we have copper excess, we use that. We use the copper-zinc relationship to help bring down the copper. So zinc at about 20 to 30 milligrams daily. Also looking for sources of copper. For zinc deficiency, I usually use the picolinate form, about 20 to 25 milligrams. For magnesium deficiency, I'll use either the malate or the glycinate form, 400 to 800 milligrams. And for constipation, we can use citrate. For the B vitamins, usually just using a B vitamin complex can actually help satisfy that. So in a B complex, I expect to see about 25 to 50 milligrams of B1, about 25 to 50 milligrams of B2, about 30 to 50 milligrams of B3, 25 to 50 milligrams of B6, 200 to 400 micrograms of B7, 800 to 1200 micrograms of B9, and about 500 to 1000 micrograms of B12. That's kind of what I expect to see in a B complex. Vitamin A deficiency, 5,000 to 10,000 IU, just being careful because 10,000 IU and greater of vitamin A can actually cause negative impacts to a fetus. So we want to make sure if they become pregnant, they tell us. Vitamin D, depending on how bad it is, we might consider a loading dose of 5,000 and up IU per day. However, maintenance doses is usually about 1,000 to 3,000. For vitamin E, 400 in mixed tocopherol form, vitamin K, 60 micrograms, and vitamin C, 1,000 to 2,000 milligrams. All right, well, unfortunately, we are actually at the end of our time. I know that a few more questions did come through. And so let's just kind of wrap up here. And if there are any additional questions, I will make sure I answer them personally via email. So thank you so much, everybody, for just kind of hanging out with me today. I really appreciate your time. I know how valuable it is. So if you have a need for additional educational materials, we'd like to encourage you to visit our website, gdx.net, or contact client services. In fact, if you have questions regarding nutrition testing and pricing and things like that, you can let client services, you can contact them and let us know, and we'll help you through that, or you can contact your sales rep. We also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results as well. We'd like to encourage you to register for our upcoming webinars at gdx.net. And if you have not already, please check out the podcast, The Lab Report. It focuses on functional and integrative medicine, specialty laboratory diagnostics, natural therapeutics, with hosts Dr. Patty and Michael, and an assortment of guests. And again, I just want to thank everybody so much for joining. I hope this was helpful, and I hope you'll be able to use this information in the future. Have a wonderful day.